Alrighty then. So, even though it's called diabetes insipidus, it has nothing to do with diabetes. Thanks, nursing school. Okay. So DI versus SIADH is an abnormality of which hormone? ADH. What do we say the functions of ADH are?
Water retention.
It's antidiuretic hormone, so it holds in sodium and what? Nope, sorry. Nope, ADH is just water.
Yeah.
ADH is just water. So it holds in just water, and it is a vasoconstrictor. Good. So I guess there's only two functions. Okay. So ADH, and it is very important to note where aldosterone and ADH, what they hold in. Let me tell you why. We are made up of salt water. When you bite your lip and it bleeds, what does it taste like? Salt. So you can taste the blood, right? Because we're made up of salt water. So if you have increased ADH, you are just holding in water, which will water down your salt. Does that make sense? Okay. So let's go back to diabetes insipidus and SIADH. In diabetes insipidus, okay, you have decreased ADH, which means you're not holding in water. You are just water. You're peeing out straight water. Like when you pee in the toilet, it is clear. It is water. It looks the same as your toilet water. That's bad for you. Because what does that leave you inside? If all your water is, you're salty. Very salty. This is caused by tumor or trauma. Very good, very good. So the number one sign and symptom of diabetes insipidus is polyuria. Poly means many. Urea means to urinate. Yes. So you are peeing like a lot. 4 to 12 liters a day. That's insane. And that's coming out as pure water. So what do you think your blood pressure is going to look like? Very low. Bad. All right. Because you have low fluid, so you have low pressure. What is your urine specific gravity going to look like? The specific gravity of water, like if I just took a glass of water and I did the urine or did a specific gravity, it's 1. Okay. Specific gravity means how thick something is, how full of junk it is. If you're peeing out straight water, it's going to be very close to water, which is 1. So it's going to be like 1.003 or something like that. Okay. What about your urine osmolality? Do you know what osmolality is? Take out the word osmolality and put in saltiness, and then you're done. So how salty is your urine? None. So it'd be very low, right? So you'd have low blood pressure, low urine specific gravity, low urine osmolality. My words are starting to go all okay. What would your urine output look like? Very high. They're going to be really thirsty because they're peeing out a ton. What would their blood or their serum osmolality look like? What do we take the word osmolality and put in instead? I just told y'all. Take out osmolality and put in the word salty. How salty are they? And serum means inside the blood. So how salty is their blood? Really salty because they've peed out all their water. So they have a high serum osmolality. That means that their sodium level would be very high because all they're left with is salt. Okay. So how I did this was these are all low, these are all high. Make sense? Okay.
Urine touches the pure water. That's why salt is salty. And blood is salt left behind.
Yes, that's right. Okay. So because they're peeing out, 12 liters a day and their blood pressure is like 90/60, they're probably going to have dry skin and mucous membrane, signs of dehydration, right? Because you done peed out everything you got. Okay. They will have hypernatremia. Now, let me tell you something really quickly about salt. I will cover this a lot in the fluid and electrolytes playlist. Okay. However, sodium, what's your normal level? 135 to 145. What nobody told me in school, and this is often testable, is that you are not symptomatic until you're in the 120s or the 160s. So if they tell you like, oh, the patient's sodium level is 131, are you going to panic? And everybody's like, oh my God, their salt is low. No, we are not going to panic. I don't give a crap. Go eat something salty and take it. That's it. What's the matter? Why does your face look like that?
So you said 120s to 160s.
Yeah, so like you're not going to get like actual symptoms. Your patient will not present with any symptoms until their sodium level gets in the 120s or high in the 160s.
Oh, okay.
Yes. So, and the reason why I'm telling y'all that, I wish somebody had told me that because there was a lot of times on nursing exams where they would give you 4 patients and say, who's your priority? And for some reason I panicked about salt. And it was like the patients had severe vomiting and diarrhea with a sodium level of 131. And I picked that damn thing every time. It is never that. They are not symptomatic and in any danger until they're in the 120s or the 160s.
That's so weird.
I know, isn't that wild? Now, potassium's the opposite. Your potassium could be 3.4 and you're like, we're running. Okay. All right, so they will have hypernatremia, and you will see as you do the fluid and electrolyte playlist that your keyword for sodium is brain. It causes all brain signs and symptoms. Headache, coma, seizure, death. So that's why in here you see neuro changes. Because their sodium levels are rising to the 160s, you're going to start seeing neurological changes. Do we understand? Okay. How to diagnose. This is one of the rudest things I think that has ever been done in the nursing world. So our urine specific gravity goes off of what we drink, right? If you drink a whole bunch of water, y'all know y'all pee a lot and it's really like lighter colored, right? So it would be a lower urine specific gravity. But that's because we have normal ADH, right? If a patient is not producing any ADH, then it doesn't change based on how much they drink or how much they're peeing. Do y'all see what I mean? So if I told you when you came in this morning, hi, welcome, we're going to be here till 3 o'clock and you cannot have a sip of water today. Okay. Do you think you would be going to the bathroom a lot? No, because your body would be like, there's no fluid coming in. I need to conserve it. So it would decrease the urine output. So what we do this patient is we're like, hey, I think you have DI. So I'm going to take water away from you for an entire day. And I'm going to watch you still pee out 12 liters of fluid. Rude. And these people are so thirsty. When I tell you it's a guttural thirst, like it's not like, oh, I'm thirsty. It's like, if I don't get water right now, I will surely die. They will beg you for water and they will find it anywhere. So much so to where before you do the water deprivation test, you have to pull out bases in their room. If there's bases of water, they'll drink it. You have to turn off the water to the bathroom because they'll go drink out of the toilet. That's how guttural the thirst is. Okay. So they deprive you of water and see if you still pee out copious amounts of urine and it still stays a low urine specific gravity. Now, what are my risks at that point? Severe dehydration to the point where they're going to go into shock, right? Y'all know shock just means you don't get perfusion to your kidneys. That's what that means. You don't get blood flow to your kidneys. Okay. Yeah. Okay. All right. So we do this water deprivation test and we're like, oh man, you're still peeing out like so much. That's crazy. So we diagnose them. You do need to treat the underlying cause, whether it's tumor or trauma. And then we give them, here's our friend, vasopressin. What do we say vasopressin was? Because it's ADH. So the synthetic form of ADH, we created medications that are synthetic ADH. It's called either vasopressin or desmopressin, or you'll also see it called DDABP. Those are all three names of the same synthetic ADH. Wow, so in DI, they're missing ADH, so we give them ADH. Not that hard. Yes? Yeah. Okay. We do need to monitor their blood pressure. What's their blood pressure look like in DI? Very low. We need to watch their sodium. What does their sodium look like in DI? Really high. They're salty. What does their urine specific gravity look like? Very low. What does urine output look like? Super high. Welcome to Endo. All right. Why am I doing a daily weight? And why did I start it and put it in a cloud? It's important. It's important. That is the best indicator of fluid balance. If they ask you which one's better, eyes and nose or daily weight, you are going to choose daily weight. And while we're on it, if you ever have an option on any nursing school exam that says good hand washing, you will pick it 100% of the time. I don't care if the first question is, what is your name? You are going to put, that is correct, good hand washing. It is 100% always the answer. Are we clear? Yeah. She's like, wait, hold on. I got questions.
Are you talking about first thing to do?
No, I'm talking about if they ever give you any test item that has the option to choose good hand washing, you will choose it 100% of the time. Oh. It is always the answer. Yes, yes. If they say, hey, what color is the sky? You would say, good hand washing. That is correct. Very good. Very good. What? It's crazy. Yes, this is real. What? I will tell you nothing that is a lie in here. Yes. It will always be good hand washing. And they'll ask you questions like, your patient, whatever, is on contact precautions. What's the most important way to prevent infection? It'll say antibiotics, put on a gown and gloves, good hand washing. It's always good hand washing. Yeah. Your patient just had heart surgery. What's the best way to prevent a post-op infection? Give antibiotics, do good hand washing, make sure you use precautions. It's always hand washing. You see what I mean? Okay. All right. We are going to give them massive IV fluids, Like here's a liter and then another liter and then another liter. And we need to give hypotonic fluids. Y'all know what that means? Yes. Hypotonic just basically means more water. It's got more water in it. And I do have a video on the fluid and electrolyte playlist about hypotonic, isotonic, hypertonic fluids. But in this case, what y'all need to know for today is hypotonic means it has more water, which would make sense because they're very salty and we need to water them down, right? All right, we're going to do neuro checks and seizure precautions. Why would I do that? What's your keyword for sodium? Brain. It causes neuro changes. So as soon as they start having symptoms, what does that tell me? That tells me that their sodium is either in the 160s or 120s, and now I got to do something because it's getting bad. Does that make sense? All right. Do we understand DI? Okay. Yes, that's correct. Okay, because hyper means nature is sodium, and then emia means in the blood. In the blood. Okay. All right. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone. I didn't write that because that is stupid. You should know it as Syndrome of Increased Antidiuretic Hormone, and that makes a whole lot more sense. But that's not its actual name. Just want to let you know. All right. No, they'll usually, you know what? I don't know. They might spell it out or they may just say SIADH. How is it actually? It's Syndrome of Inappropriate Antidiuretic Hormone. I'm like, that could go either way. That's stupid. They should have named it Syndrome of Increased ADH. So where's your fluid in SIADH? Your water. Where's your water? All inside your vessels. That's very important to note. It stays in your vessels. I put that in your patho. Guess what causes this? Tuma or trauma. Okay. So if it stays in your vessels, you have more fluid, which means more pressure, right? If there's more fluid, there's more pressure. So your blood pressure is going to be very high. So then how much urine output are you having? Not very much. So whatever you have coming out is going to be thick. That means your urine specific gravity would be high, over 1.035. And just so y'all know, in case you don't know your lab values, I have a whole lab series on YouTube to help you out. You don't have to do all of those, but just letting you know it's there. This is a normal urine specific gravity, 1.010 to 1.035. When they have DI, it'll be like 1.003. When they have SIADH, it'll be like 1.040 and up. Understand? Okay. All right. So are they peeing out very much at all? What's the term called for you're not peeing out very much at all? Okay, so if polyuria meant peeing out a lot, oliguria means not peeing out much. Anytime you see the word olig in nursing school, it means little or less. Okay, because like when we go into OB, we'll do oligohydramnios, which means low amniotic fluid. Okay, so oliguria means you're not peeing out very much. Okay, so all of your water is held in. So are you salty or are you not salty? You're holding in just water, right? So your sodium would go low. Your urine output, low. Your serum osmolality would be, that's the osmolality in your blood. What do we replace osmolality with? What word? Why can't y'all remember this? The third time we done it. Salty. Okay, so are they salty? No, so that would be a low serum osmolality. Now their blood pressure is very high, and the urine specific gravity would be high because not much is coming out. What is coming out will be thicker, right? Okay. They will probably be in what's called fluid volume overload. That's FVO, fluid volume overload. Okay, because they've got so much fluid and they're not peeing hardly any of it out. So their pulses are going to be like ba-boom, ba-boom, ba-boom with all that fluid. That's called bounding pulses. You may auscultate and see, not auscultate, you may palpate, JVD. What's JVD? Jugular venous distension. This is always on your test for health assessment, by the way. To assess JVD, I'm just going to tell you so that way you know when the test comes. You set them up at 45 degrees, turn them to the side, and then you watch it, and it's like boom, 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 because there's so much fluid. Okay? And then you may hear crackles. How come? There's fluid in the lungs because the heart can't get it all out because you're in fluid volume overload. Yes? All right, how do we diagnose this? Okay, anytime I write on these papers clinical diagnosis, that means there's no test that definitively will diagnose. So we use our best clinical judgment. I'm like, based on your signs and symptoms and your history, I'm going to diagnose you with this disease. Does that make sense? Mm-hmm. Okay. All right. So how do we treat SIADH? What do I need to do? I need to get rid of the fluid and get them peeing, right? Right? Mm-hmm. Okay. I also need to fix that blood pressure. What's the worst case scenario of high blood pressure? Not low, high. Why do we always worry about blood pressure if it goes high? Stroke. Because the pressure goes so high in your brain that you blow out a blood vessel. Okay. So we're probably going to try to prevent that, right? Mm-hmm. So we're going to give antihypertensives to lower the blood pressure. And then we're going to give a drug called mannitol. Do you know what this is? It's a diuretic for your brain. So it just pulls fluid off the brain so you don't stroke out. Okay. And then we will give hypertonic saline. So I talk about this in the fluid and electrolytes playlist, but for this case only, when we're talking about fluids, you're going to take the word tonic and replace it with salt or sugar. Okay. In this case, it'll be salt. So hyper means high. Tonic in this case only means salt. So you're going to give them a high salt solution, like normal saline 3%. What's a normal saline that we give every day? Like if I said, hey, go give normal saline to your patient, what percentage is that? 0.9, right? And this is 3. Yeah. It's very salty. The important thing about hypertonic saline and salt is you have to give it really slow because you know that water is attracted to salt. So if you give a patient a bunch of salt, all the water in your body is going to follow it. It's going to cause brain swelling and you will die. So when you give a very salty solution, you got to just very, very slow or you'll cause their brain to swell. Okay. All right. For SIADH, we need to monitor the ICP. What is ICP? We're worried about their brain, right? Okay. So yes. What are you worried about happening when they have all this? It's not inflammation. When they have too much fluid up there, that's what we're worried about, right? Mm-hmm. So that's intracranial pressure. ICP is intracranial pressure. I'm worried about them having so much fluid in their brain and so much pressure. Okay. So we have to watch their ICP, intracranial pressure, and signs and symptoms of a stroke because worst case scenario of high blood pressure is stroke. Okay. And we also have to watch for signs and symptoms of CHF, which is congestive heart failure. It's okay. It is chronic. I mean, you're not wrong. And what is the first sign and symptom of CHF usually? What's the one thing you want to listen for with CHF? We also, because we did it with cardiomegaly and hyperpituitarism. We're doing it with SIADH. It's crackles. Okay. Now, we are going to do I's and O's, but what's a better indicator of fluid balance? Daily weight. Why would I put them on a fluid restriction? They already have so much fluid. I'm going to have to be like, look, you can have one tiny cup of fluid today, and that's it. Here's one ice chip. Have a good day. Okay. Why are we doing neuro checks in this case? Okay, I can agree with that. We are giving them salt. Why am I giving them salt? Okay, so their sodium level is low. They have a lot of water. What's your key word for sodium? Brain. It's neuro changes. So if they start having neuro change, honestly, if this patient started having neuro changes, I'd be like, well, it could be increased ICP. It could be a stroke. It could be too low of sodium. I mean, there's a million different things it could be with this. Yes? Okay. So it's something we really, really got to watch for. Do you understand DI versus SIADH? Yes? We did it. We did it.